substantive agenda items today. The first is the staff is going to make a presentation relating to possibly exempting certain hospitals from budget review hearings this summer. And then second, our Director of Health Systems Policy, Elena Barabee, will provide an overview on developing a hospital reference-based pricing program. Before we get started, I did want to introduce and welcome our newest board member, Sarah Teachout. Sarah had previously worked at Blue Cross Blue Shield, and she brings a wealth of experience from the insurance side of our regulatory process. Sarah was the lead lobbyist for Blue Cross, and as somebody who had to sit on the other side of much of what she was advocating for, I can say she was quite effective. At the same time, she was also incredibly professional, always prepared, and extremely bright. And I'm really thrilled, as is everyone, that Sarah has joined the board. So welcome, Sarah.
Thank you, Chair Foster, and everyone else here. I really appreciate it.
With that, I'll review the meeting minutes from June 11th, and I move to approve those minutes. Is there a second?
Second.
All in favor, say aye.
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 Aye. And the vote carries 4-0. And I'll turn it to our Director of Health Systems Finance, Mr. Sutter. And also, it is Mr. Sutter's birthday today. So happy birthday, Mr. Sutter.
Thank you, Chair Foster. Let me pull up our presentation. Give me 1 second. All right. We'll jump right in. We have a pretty short presentation about the possible hearing exemptions. Just the agenda. Mark Hensler from our legal team is going to discuss statute and rule with the board and explain what it means basically to exempt a hospital and the implications of that. Then we'll go through the staff recommendations for Grace Cottage North Country Hospital and NVRH. We'll also briefly present a hospital requested exemption from Brattleboro Memorial Hospital and then move to a potential vote. So if Mark's available, I will pass it to him.
Hey, good afternoon. So what I'm going to do today is briefly review hospital budget, benchmarks, hearings, and the process to exempt. I'm just talking about benchmarks and hearings today in the context of what it means for the board to decide whether or not to exempt a hospital from budget review. Next week, staff are going to be kicking off a more detailed description of the hospital budget review process for FY26. And in that presentation, we'll discuss some of these materials again and speak more directly to elements of the FY26 guidance document that's relevant to this process. We're not talking about that document today. We're just talking about the limited aspect of how the benchmarks and hearings work so that the board and public can move on to the exemption requests. As a starting point, the board has rules which concern a number of factors, including how the board establishes benchmarks and what it means to use benchmarks, what the purpose of benchmarks. So as a starting point, Rule 3.202 provides that on an annual basis, you can go ahead and go back a slide, Matt, if you don't mind. The board will establish benchmarks for any indicators for use in developing and preparing the upcoming fiscal year's hospital budgets. As was done this year, the board will meet with Vermont hospitals and the Hospital Association and any other interested person on or before February 15th in order to obtain input prior to establishing the benchmarks. The benchmarks shall be included in the Uniform Reporting Manual provided by March 31st, and that reporting manual includes in part the what we call the guidance document, and that guidance document is where we house the benchmarks. This section also details what benchmarks are used for. So the reporting manual benchmarks will allow the board to, one, make a determination whether to waive the need for a hospital to present its budget at a public hearing. That's what we're talking about today. And two, determine whether a budget may be adjusted. You can go ahead to the next slide. So with that, I'll give a little framework for what it means to use benchmarks and how these exemption hearings or these exemption decisions fit in. At a high level, I just want to talk about what benchmarks are in statute and what benchmarks are described as doing in rule. So highest level, 18 VSA 9456, which is the board's hospital budget review statute, states that the board may establish a process to define on an annual basis criteria for hospitals to meet, such as utilization and inflation benchmarks. The board may waive one or more of the review processes listed in the hospital budget review statute, which is subsection B of this section. The formatting of this has actually changed very slightly with 2025 legislative action that's not yet in the Vermont statutes online. But I just want to flag that what's in statute is that the board may use benchmarks, and the purpose of benchmarks is to allow the board to waive one of the review processes that are otherwise required by statute. And there's a big list of review processes in 9456. Separately, our rule does speak to how benchmarks are used. Rule 3.303 provides that the benchmarks established under the section we just looked at shall guide the board in its decisions whether or not to adjust a hospital's proposed budget. I'll stop there and say that benchmarks are used to guide the board. Benchmarks are not used to limit or constrain the board from taking whatever statute actions that it deems necessary under statute. Rule 3.305 states that the board may adjust the proposed budgets of hospitals that do not meet the established benchmarks. But just to be clear about this, the opposite, that doesn't mean the opposite. So the rule states that the board may adjust budgets for hospitals that don't meet the benchmarks, but there also can be situations where the board may need to adjust budgets of hospitals that have met benchmarks. The reason for that is the 9456 has a number of factors the board needs to consider when it establishes a hospital's budget, and the benchmarks are not designed to capture every single one of those statutory factors. The benchmarks are designed to capture a few core elements of a hospital budget and assist the board in its understanding of what hospitals to review and how to review them. You can go ahead to the next slide. So with that, what we're talking about today, which is exemption from hearings, this is the part of the budget rule that actually allows the board to take an action on hospital budgets that constrains adjustment of the budget. So I'm just going to go over what this process is. The public hearing section of the GMCB rule 3.302 provides that the board may hold public hearings concerning budgets, and that the board at its discretion may require hospitals, except for those exempt, which is what we'll be talking about next, to provide testimony and respond to questions raised by the board or the public. And then to the next slide, this is where the exemptions finally come in. So 3.304, in the event that the board holds a public hearing or hearings, the board may exempt a hospital from those hearings if the hospital met the benchmarks established under section 3.202. This is the point that's important today. An exempted hospital will not have its budget adjusted for the year in which it is exempted. So this is the sole scenario where the board is if the board exempts a hospital from a hearing, it is making a determination that it's not going to adjust what the hospital has submitted in its budget, and that goes back to those benchmarks. The rule further explains that in a given year, no more than 4 hospitals may be exempted from the public hearings, and that the 4 largest hospitals, as measured by last year's NPR, shall not be exempt from the hearings. And then on to the last slide for me, Matt. So with that, before this hearing, staff sent out letters to 3 hospitals. I just pulled the one from Grace. It was the first one on our website. And what staff laid out for hospitals is aligned with what's in the rule. So what staff have shared with hospitals that are being recommended for exemption this year is that should the board approve the staff's recommendation to exempt these hospitals, the hospital's core budget components that were those benchmark components will not be adjusted. So what it means for a budget to not be adjusted when the board exempts a hospital is that the hospital's proposed total NPR growth will not be adjusted from what was submitted. The hospital's proposed commercial reimbursement cap shall not be adjusted, and the hospital's proposed operating expense cap shall not be adjusted. Those are the three items that, if exempted, will not be adjusted by the board. I'd say that to separate that from a separate action the board takes in the budget process, which is issuing standard hospital budget conditions. Hospitals have been informed that if they accept a board-approved hearing exemption, the hospital will still be subject to any and all standard budget conditions that are established by the board at a later date. Those standard budget order conditions may include additional reporting requirements and conditions to ensure consistency with new law. In addition, staff are intending to propose one addition, which is a commercial net patient revenue cap, and that would be a standard budget condition. And that would not be, that commercial net patient revenue cap would not be something that these potential exempted hospitals would be alleviated from. They're required to abide by these standard conditions. So I share that just to give context for one. This is the process to exempt hospitals from hearings, which means holding to the proposed budgets that have been submitted for these core areas. And two, there is still a separate process for standard budget order conditions, which will apply to these hospitals, even if they accept these exemptions from hearing.
Excellent. Thank you, Mark. Jumping quickly to the staff recommendations, the budget submitted by these three hospitals met the benchmarks established by the board. You can see for NPR growth, Grace Cottage was under benchmark at 3.4, North Country at 2.4, and NVRH at 3.4. Operating expense growth, Grace Cottage at 2.6, North Country 2.9, and Northeastern Vermont at 1.6. Then commercial reimbursement rates at Grace Cottage was nothing, North Country 0.5%, and then benchmark at NVRH. I did want to add quickly, in case anyone's doing back of the napkin math for NVRH's benchmarks, their NPR and OPEX growth needed to be adjusted to account for the annualized impact of the mid-year adjustment that was approved in earlier June. Another errant keystroke. Thinking about these in terms of system impact, these are relatively small hospitals. Combined, the three of these account for about 7% of the system net patient revenue, and less of the commercial net patient revenue at about 6.3%. When we look at the submitted budgets from the hospitals there, these hospitals have budgeted very modest operating margins, and system-wide represent less than 3% of the budgeted operating income across the system. Staff also reached out just to make sure we understood any service line effects of approving the budget as submitted. Grace Cottage confirmed there were no service line changes, same for North Country. At NVRH, there's a very small change where an occupational medicine, a part-time provider nearing retirement, they've told us they've had some difficulty replacing the position and have strategies to support existing services that might be lost, but local businesses are largely using other options for occupational medicine as is. But they identified this as an expense cut to the system too of about $300,000. I did want to mention Brattleboro Memorial Hospital has submitted a letter to the board requesting that they be exempt from hospital budget hearings this year. The letter is linked below, and it's on our staff website or GMCB website on the individual hospital budget page. However, staff does not recommend approving this request, as there's a number of questions we have still out to them that we would need answers to make a recommendation along those lines. At this point, we can take board questions. Mark's prepared draft motion language in case we vote, but that's the extent of our presentation. So happy to take board questions. Thank you.
Thank you very much, Mr. Sutter. Any board questions or comments? Okay. I support the staff's recommendation as it was laid out, so I'll go ahead and make the motion. I find that Grace Cottage, North Country, and Northeastern have met the fiscal year 26 guidance benchmarks established under GMCB Rule 3.202, and after considering the proposed budget submitted to the board, move to exempt these hospitals from public hearings under GMCB Rule 3.304. As described in the board's letters of July 24th, 2025, budget orders for these hospitals will not include adjustments to the caps on proposed total NPR growth, proposed commercial reimbursement growth, or proposed operating expense growth. Budget orders for these hospitals will include all standard budget order conditions to be established at a later date by this board.
Second.
Any other board discussion on the motion? And any public comment on the motion? I'll start with the healthcare advocate, Mr. Peisch.
Good afternoon. Good to see everybody. Feels like it's been a little while. So our office, we support the concept of exemptions. I mean, I think Mark did a really good job laying out the rule. I think it's a good idea to reduce kind of unnecessary hearings when possible. We do have some concerns about the hospitals that are selected. We don't dispute that that met the 26 benchmarks, but given what we've seen, and maybe they're more updated information about their financials in Q1 of FY25, the financial positions for Grace, MVRH, and Brattleboro were really concerning, like negative operating margins of 11.8, 5.1, 13.6. We agree with the staff recommendation to have a hearing for Brattleboro. But for Grace and MVRH, I think it would make sense for the board at least to have like a focused hearing to get some questions out and to learn more about what their kind of corrective action plans are. We do support exemptions for Mount Escutney and North Country. It seems like they're on much more stable footing. While there are some concerns, their operating margins are a little bit more positive. I think one of our fears is, as Mark helpfully mentioned in Rule 3.304, is the inability to adjust budgets. And I think I worry about kind of the board being restricted in its ability to modify the budgets of hospitals that are struggling. So I just wanted to put that out there for the board's consideration. And again, like, we support the concept totally, but I think we would have selected some different hospitals, and happy to speak more about those. But thank you. Appreciate it.
Thank you. Dr. Gulper?
Thank you, Chair Foster and the board. It's just a point of information only. Is there a systematic drill down on service line changes? So when you report that the budgets are and revenues are stable and there are no service line changes, is there a drill down that the board actually reviews to confirm that?
I think I can take a stab at that. There's two things. One, there will be questions to some hospitals about potential service line changes. And then two, under some of the legislation that was passed this year, hospitals have an obligation to report service line changes to the board. And then in terms of the hospitals that we would be reviewing in full, that's certainly something that can come up in our hearings as we evaluate the budgets. And one other comment in response to the healthcare advocates, I think that the ability to monitor some of these hospitals that we'd be potentially exempting if the motion were to pass continues. Obviously, this doesn't remove that aspect of it. It does remove the aspect really of just whether or not we change their budget. But in terms of monitoring and keeping track of what's going on and working with them, that is not removed by this motion. Any other public comment at this time? Okay, I'll call for a vote then. All in favor, say aye.
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 Aye. And the motion carries unanimously. And I did want to thank the hospitals for working really hard to work with our staff and be mindful of the guidance this year. It wasn't easy. We realize there's financial challenges at these and every hospital to some degree, and these hospitals worked hard to hit the guidance. And I appreciate the opportunity to remove some of the administrative burden and regulatory burden that that a regulatory process imposes. So thank you, and thank you, Mr. Sutter. Next, I'll turn it to Ms. Barabee.
Hello, thank you for having me. So I'm going to share slides. Can you all see the slides?
Yes.
Okay, so I'm Elena Barabee. I'm the Director of Policy at the board, for folks that don't know me. And today I'll be providing an update on recent legislation, kind of what we've been thinking for developing a Vermont hospital reference-based pricing program. So just to tell you what we're going to go through, basically what we're recommending, staff are proposing a phased approach to hospital reference-based pricing. So a comprehensive statewide implementation is a big lift. And so it's iterative and we need to take the time to get it right. I think we've talked about other states who have tried to adopt similar an approach, but that has largely been done in a much smaller scale and setting. And so this is kind of a novel idea doing this statewide. So I think it's important we take our time. The bill also calls for hospital global payments as a possible next step to reference-based pricing. I just wanted to kind of outline some of the other context related to that work. I think in the bill, it says it, and we'll go through the language later, but it's really kind of sequential to reference-based pricing, and we'll talk about the timelines when we get there. Medicaid is implementing a voluntary payment program in 2026. Medicare, we were previously exploring what a global payment could look like for a Medicare program under the AHEAD model, but this program is being revised by the new administration, and they've postponed program implementation to 2028. So we're still learning about what that program looks like and whether it still has kind of any of the same components of the previous model. In the commercial program, payers and providers would need to demonstrate commitment, and we would need additional resources to actually make this work. If it happens within the context of the AHEAD model and the state does go forward, there is some federal money there, but we do not have money outside of the context of the AHEAD model to advance that kind of reform. So some background. So as I mentioned, the Vermont legislature passed Act 68 earlier this year. This directs the Green Mountain Care Board to implement hospital reference-based pricing through its provider rate-setting authority, which we have had to date, but we have not had resources nor explicit direction to put it into practice. And they want us to do this no later than fiscal year 27. So this would mean right now you're looking at fiscal year or about to look at fiscal year 26. So this would be for next year. This came out of a response to ongoing concerns regarding Vermont's healthcare affordability crisis, which no doubt is top of everyone's mind. Reference-based pricing is an opportunity to remove price gouging, reduces unaffordable outlier prices for particular services or in particular geographies, and incentivizes efficiency under a cap, if you will. Reference-based pricing also ensures sufficient healthcare dollars are available to support non-hospital providers. I think some of the challenges we've been hearing about across the system are that, you know, once many of the prices have been negotiated, there's not much to go to kind of smaller, more preventative or community-based providers. The objectives outlined in the Act, so I should mention that hospital reference-based pricing was just one component of a larger suite of reform initiatives, which we'll mention later, but the goals of the broader bill were to enable improvements in health outcomes, quality of care, and regional access to services, to enable an integrated system of care with robust care coordination, increased investment in primary care, home health, and long-term care, to stabilize healthcare providers by reducing commercial health insurance premiums and managing hospital costs based on the total cost of care, beginning with reference-based pricing and continuing to hospital global budgets. and improve population health and increase access to care. So this is really about continuing to advance the triple aim and some of the principles of healthcare reform that we have been trying to tackle for many years. So what is reference-based pricing? I think there have been a lot of questions and a lot of assumptions. Hospital reference-based pricing is establishing a maximum amount that hospitals shall accept as payment in full based on a percentage of Medicare reimbursement or another benchmark as appropriate. Payment in full means that it should include that which is paid by patients. So we're not expecting any cost shifting to happen beyond this maximum price to patients. It all needs to be baked into this price. Establishing a maximum amount could be a methodology, it could be an aggregate, it could be very detailed. There are a lot of kind of ways that this could be operationalized, but it's very high level direction to start thinking about this with stakeholders. In establishing these prices, the board shall consider the composition of communities served by the hospital, including the health of the population, demographic characteristics, acuity, payer mix, labor costs, social risk factors, and other factors that may affect the cost of providing hospital care in that service area. So there is some ability to think about, not establishing a one-size-fits-all, but recognizing kind of the different roles and needs across communities when setting these setting reference-based prices. Part of this work, we will consult with health insurers, hospitals, and other healthcare professionals of the Office of the Healthcare Advocate and our partners at the Agency of Human Services. Once we have established kind of a method, the statute calls for the board to review prices annually as part of the hospital budget review process, and to establish monitoring in collaboration with DFR to assess kind of where the decrease amounts in terms of price are is that translating into premiums, and to identify any factors that might necessitate termination or modification. So we want to make sure that as we're implementing this program, that we have a way to identify any unanticipated consequences and evaluate whether this is serving the initial intent. So can't we just press go? So as I mentioned, there are a lot of other states who are talking about reference-based pricing or have implemented reference-based pricing, but this has largely been done through public employee benefit programs. So it's very different than the statute that we have here. Only one other state has implemented hospital price caps through provider rate setting, and that is Maryland, and their model is a little bit more intricate and has evolved in recent years, but is really, the only other state doing provider side rate setting at this point in time. In talking with some of these other states, they are looking for opportunities to grow. They have seen a lot of success in the programs that they have implemented and thinking about how to scale their reference-based pricing programs. So there's a lot of work that needs to happen since there's no off-the-shelf product that we can just plug in here in Vermont. And of course, we have some unique challenges that we're going to have to think through. So part of this work is going to entail policy scan and doing a gap analysis on kind of our data assets. There are a lot of changes kind of at the federal level that may affect kind of how we might want to approach this, and leaving room to be nimble. We don't want to design something that may become irrelevant or may be a difficult fit in a couple of years. So I think it's important to make sure that we're considering ways to adapt. We need to think about how this would look for different communities and when and how we should make adaptations. We're going to need to think about, our existing data assets. As I mentioned, we currently don't have a lot of the self-funded claims data. A lot of these plans, implementations of this kind of program have relied on claims, so making sure we have all the claims, or we have methods for estimating missing claims. So there's a lot of kind of analytic work that needs to happen in the design phase, and then we need to start building the infrastructure, and that will also take time. So I won't read every detail to you on this slide, but I think I just want to convey the amount of work that needs to happen. We have to get through the state's procurement process to solicit support, and so we just want to make sure that we're moving forward quickly, but also thoughtfully, and making sure that we're taking all the necessary steps. In terms of the implementation strategy, so while it will take time to kind of get through this kind of the more comprehensive implementation, we do think there are things that we can do for FY27 that move us in this direction. So we think that we could set benchmarks for hospital price adjustment based on relative price or other relevant factors through the hospital budget guidance. And we could explore perhaps establishing a freeze as a % of Medicare while we implement a more permanent program that kind of is done through the rate setting mechanism. We think that it's still an aggressive timeline to hit FY28 to have a rate setting methodology in place, but we think we can do it if everything kind of goes as expected. And so that is kind of our target date for this kind of more robust program that, again, I think even at this stage, we would still be learning as we're implementing and want to leave room to evolve as we learn more. This is just to kind of reiterate the timeline. In order to get to that FY28 implementation through rate setting, we really have to start this work now. So I think there will be a parallel process, and this kind of assumes that our contracting processes are smooth and expedient and that we have no major challenges in developing data infrastructure. I don't think there's anything in that will prevent us from being able to implement this program, but I think it's just a matter of how much time it will take to work out the kinks. So, there's a lot of learning that we're going to do along the way. We've already kind of started building collaborations with other states that have done this and learning communities, so we can hit the ground running, but just, want to be upfront that this is a big lift. How are we managing this work? Right now, I'm kind of spearheading this. We are hiring additional support for this work in particular, and we'll get, I think maybe one other position posted in the near term to help direct this work. But this will require expertise from across our organization. So, our operations, data and analytics, finance, certainly how does this intersect with the budget process, and our legal team, as well as this outside expertise. So it's not just going to be one person, but it's going to take a team of people to get it to where it needs to go. Again, we're going to have to work with many stakeholders, those listed here that I mentioned before, and certainly others. Part of the legislation calls for us to go before the legislature to share the proposed methodology before entering the rulemaking process. So that is another kind of milestone we have to keep in mind. And then certainly the board will have to vote on adopting a proposed rule before the pre-filing. And so we'll be giving you updates and kind of soliciting feedback along the way. So the hospital global budget language, I just wanted to reiterate, the called for us to implement hospital global budgets by FY28 to the extent that resources are available. And then not including critical access hospitals, but by 2030, to the extent resources are available, shall establish budgets for all hospitals. I think given that, we don't have resources outside of the AHEAD model to pursue a global budget methodology, we do have kind of tools within the hospital budget process that can get us close to a hospital budget, global budget methodology if you have the reference-based pricing component with it. So that's something we could think about doing later on. But certainly by 28, this feels a little challenging to do without additional resources. I also want to highlight some other policy considerations. So I think, we've learned a lot over the last several decades of reform work. Payment reform alone is necessary, but not sufficient to actually move the needle and where we want to go. So we need to co-consider affordability, access, and quality. We can't just tackle prices. We have to think about how what those prices mean, what they're intended to cover, and the implications for patients. Providers that are already struggling, even within a reference-based pricing program, may continue to divest low-margin services, and that could affect patient access, quality of care. One thing we've been thinking about is how could we, design a methodology that would allow us to kind of help, prioritize some of those services that may have historically been lower margin, or, are there opportunities to rethink how we're allocating resources? So I just you are all aware, we've been doing kind of this related work for a while through Act 167 and the stakeholder engagement process, which led to the Oliver Wyman report and some recommendations to consider kind of broader system transformation. Our partners at Agency of Human Services have kind of taken this work on through Act 51 and are working with hospitals now and are thinking about regional planning to reduce inefficiencies, lower costs, improve health outcomes, reduce inequities, and increase access to essential services. So I think, this work is happening. Act 68 goes further and tasks AHS to facilitate the development of a statewide healthcare delivery strategic plan. And so it will be important that we work in close collaboration with them to ensure that all of these levers are kind of working together. As I mentioned, they are kind of in the throes of developing regional transformation plans. And then I think there's the other thing that our partners have been talking about is some of the transformation funding that has been made available at the federal level through the One Big Beautiful Act, which has $50 billion to support rural health system transformation over 5 years. So I think there's still questions about how that program will be administered, but really in order to take advantage of that opportunity, a plan has to be in place and applied to the federal government by the end of the year. So this comes at a great time, but might be a big focus of folks in the next several months. So next steps, we're planning to finalize our detailed project plan and share that more publicly and get some feedback from folks. We'll finish developing a stakeholder engagement and communication plan. So we'll start reaching out to the stakeholders that we've mentioned before and others to help us in this work. We'll notify our collaborators of the process and timeline and like I mentioned, gather feedback. We'll identify necessary contract support and start issuing RFPs to support this work. And of course, we still have to hire folks. So I'm going to kind of keep shepherding this, but hopefully we'll have some help soon in terms of a project lead. And then certainly we need to continue collaborating with our other state partners and agencies to ensure that this kind of program works along well with other efforts that are underway. We also, as part of the bill, I didn't spend much time talking about it here, but can come back at a later date, asked us to start advancing kind of a primary care payment reform. And so there's an opportunity to establish floors or think about other ways of strengthening primary care through our rate setting authority. The Vermont Steering Committee for Comprehensive Primary Care is going to convene, I think, in the next few weeks and really start their work. And so we're to work with them in this kind of payment space as well. So there's more to come on that. Okay, and with that, I will answer any questions.
Thank you. I'll open up to the other board members for any questions. Should I call on member Teach Out first, just to break her in?
I thought it was a pretty thorough presentation, Elena. I know there's a lot of work to do. When do you anticipate having new staff members on board to help you?
Yeah, so we're hiring right now for some help and an affordability pricing project director. I'm really hoping to get someone in the door as quickly as possible. And then I think we have to think about whether that person will manage the program or whether we have someone else direct the program and have them move to more affordability monitoring work. So, hopefully here in the next couple of weeks, but I think, finding the right structure is going to take some time as we work through what this work looks like.
Thank you.
I had one question, and it relates to slide, I think it was 5. Yeah, Act 68, it discusses the board in establishing prices to consider the population health, demographics, acuity, composition of the communities. And I appreciate that that's in the statute. That's important. It can't just be a price because that may not consider what's going on in terms of access and quality as well. But in terms of those other states that have implemented it, at least in part for some payers, do they consider that? Do you know? And how do they take that into consideration?
That's a great question. So I think some states have carved out critical access hospitals entirely from their reimbursement methodology. Many of the programs that have been implemented to date have stayed at a more aggregate level, and they're kind of working through that right now as they're getting down to the service level. So we'll continue to learn for them, but one option is to just apply this to some hospitals and not others. But I don't think that they've done, they haven't adjusted different prices. Usually it's inclusion, exclusion criteria. But we're going to do more of a policy scan so we can identify if anything's changed since my understanding of how that's worked.
It sort of reminds me of rate review, where you do have a math equation to it, and then you have a number of other things that are soft factors, and how we balance those two considerations. So if you just do the price factor, it may not work, but then it gets into the non-mathematically available things. So, okay, I think that'll be interesting, and I'm sure the engagement will be robust with insurers, HCA, and hospitals to help us get that right. Thanks.
Can I just make a quick comment too? Thank you, Elena. The one comment I wanted to make just was I wanted to clarify slightly on the ahead timeline. I don't think formally it's been announced that it's 2028, so 2027 is still a possibility because the formal designation hasn't been made yet. So, but that's a lot of what we've been hearing. So, but otherwise, I think this is really interesting work, and I know there's a lot to do, and optimistic about it. Thanks.
I don't have any questions for you, Elena. I know this is going to be a tremendous amount of work, and I have no doubt that you're going to hire a fantastic team to help you with this and engage stakeholders. And there's always lessons to learn from other states along the way. And, it might be helpful to create like a working group among other state leaders as they're trying to, so it's iterative and continual learning as all these states are trying to, or some states are trying to implement it, and they're all on different timelines on it. But I appreciate it, and I look forward to that policy scan and learning more from successes in other states and the challenges in other states. But thank you.
No questions from me either. Just thank you for the work you're doing here, and I look forward to watching it.
Any comment from the healthcare advocate?
Yes, thanks, Mr. Chair. First, I just can't help but say, I've said it on the record many, many times, I for one, am not putting any eggs in the ahead basket, whether it's for 27, 28, 29. I'm not putting any faith in that being anything useful for Vermont. But that's an aside. I think I understand that this is taking longer than we want it to. I have to accept that. I'm frustrated by it, but I'm also not surprised by it. I think it leaves me with a question, though, of what's going to happen for 27. And I don't know what the board and board staff is thinking about for 27, but I do want to at least say out loud, I'm fearful of another year of doing the same hospital budget guidance. We think we need to move in the right direction, and certainly will be happy to engage in discussions about how to do that.
Thank you for that comment, Mr. Fisher. I think you're right. I think everyone would rather move to this or start getting closer faster. In reflecting on this year's hospital budget guidance, there was always a timing issue between when we get the rate filings and when we do guidance and start developing it. We have had preliminary discussions about changing our guidance process quite a bit for next year. Potentially, I think Elena was alluding to this, moving towards something that does distinguish between high-priced hospitals and hospitals that are not, and having a different guidance level. That's a possibility. Another piece that we might be talking about, I mean, we're early stages. We're not even doing hospital budgets yet for 26. But those types of things are under consideration. How do we bring in quality more front row in our budget review process? And then how do we bring in affordability more front row in our process? And also looking a little bit deeper on some of the 9371 factors and taking a more proactive approach on some of those, just given the context in which we're going to be regulating this year and next year. So we're very cognizant of your concern, and we're going to be engaging with people, I think, earlier than we have ever before on starting that new process. I can take public comment via raise the hand. Good afternoon, Walter. Good to see that you're not out in the heat.
Hey, oh, and yeah, I'm not out in the heat today with my sun hat on and everything else, and amidst the swirling dust. It's 105 on Monday, and I walked 8 miles that day. I just want to back up what Michael said about a head model. We've been through all these managed care things. The ACO was a complete failure, and I don't see how a head is going to do any good for Vermont either after we spend more millions on it. It's just just another managed care thing that's just an excuse to avoid what we should be doing.
Thank you, Walter. Yeah, I mean, we don't even have all the changes yet that are being proposed. So once you get the changes, you have to understand them, then you got to evaluate them, and then you got to decide, and that takes a lot of time and money. So it is a shifting landscape on the ahead front. I think that the skepticism is fair. I think the board was pretty skeptical as a group back in January with the first iteration.
Yeah.
So, look, I think we have to be a little bit open-minded that if there is an avenue that's more advantageous, we got to be open-minded. But I share the skepticism with you. Any other public comment? Okay, seeing none, I can move to new business and old business, and I have a piece of old business, which was that on June 13th, the board issued a decision on Blue Cross Blue Shield's 2025 large group rate filing, and the board's required to announce this decision at its next public meeting, which is today. Large group filings establish a formula, a manual rate, and accompanying factors that an insurer will use for large group renewals. Because large group premiums are experience rated, the filings do not establish the premiums any particular large group will pay. Blue Cross requested the request that Blue Cross made would have resulted in a 17.3% pure manual premium increase. That is a 17.3% increase for a hypothetical large group renewing with zero experience credibility, average demographics, and no underwriting or management discretion applied. The board ordered Blue Cross to make several modifications to the filing, and the modifications reduced the pure manual premium increase from 17.3 to 13.7%. There had been some reporting on this decision that was just for the large group. And again, that's not actually the rate that people will have given the experience rating. It's the formula by which they will apply it. The board is currently deliberating the other QHP plans, small group and individual. Decisions will be issued on August 22nd for those. Seeing nothing left on the agenda and no public comment, I will move that we adjourn.
Second.
All in favor, say aye.
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 Aye. Member Teachout, your good luck. We're unanimous on every vote today. Let's see how long that lasts. All right. Thank you, everyone. Have a nice day. We're adjourned.